Good morning, everyone. Our next Monday has come. We are going to discuss today that what exactly a palliative care physician should do when it comes to gynae-oncology or gynecological emergencies or gynae patients. For this, again, SMS Medical College Jaipur, I am really proud of them that they have started just 2 years back, and their residents are ready to give seminars in the at the national platform. And I'm proud of their teachers, Ashwin and Dr. Yogendra, who is going to moderate today. So I know Yogendra very well, that he was in our CTC program and he was trained in the throughout 1 year. He left anesthesia and he joined Department of Palliative Medicine as an associate professor with Ashwin. Uh, I request Yogendra to introduce Surendra. I think I met SMS Medical College residents in at Bangalore, but still, it's your opportunity to introduce Surendra Yogendra. So please introduce him and start your seminar. So anyone has any questions, write down in the chat box. Dr. Yogendra will take at the end. So go ahead, Yogendra, please.
Thank you, madam, for appreciation of SMS Medical College. Good morning, everyone. Today's speaker is Dr. Surendra Kumar Pingoliya. He is second year MD resident. He is from Jaipur. He is very sincere and disciplined guy. Now, today he is going to present palliative care in gynecological malignancy. Shall we proceed, ma'am?
Yes, please go ahead.
Good morning, respected teachers, my seniors, and my colleagues. Thanks for giving me this opportunity by IAPC. Today discuss my topic, palliative care in gynecological oncology. Overview include these topics: introduction, most common gynecological malignancy, concern in gynecological malignancy, symptoms management in gynecological malignancy. Palliative care focus on specific and severe symptoms resulting from affected abdominal and pelvic organs and genitals. These symptoms are mainly connected to advanced gynecological malignancies. Patients with locally advanced or recurrent gynecological cancers may present with various symptoms. Approximately 80,000 new cases of all cancers detected every year in India. From them, 10 to 15% are gynecological malignancies. Most common gynecological malignancy, it includes carcinoma cervix, carcinoma ovary, carcinoma endometrium, carcinoma vagina, carcinoma vulva. Carcinoma cervix. Cervix is the lower narrow end of the uterus at junction of the vagina. It is fourth most common cancer in women worldwide and second most common cancer in Indian women. It is contribute 1.5% of all cancer death. 99% of CS cervix associated with human papilloma virus. Most common human papilloma virus 16 and 18 and other subtypes 31, 33, 45. Site of metastasis of cervical cancer includes direct invasion of cervical stroma, vagina, and parametrium. Hematogenous spread most commonly to lungs, liver, and bones, mainly bone, lumbar, spine, and pelvic. Lymphatic spread, common iliac, para-aortic nodes, incidence 18.3 every 1 leg. CA ovary begins in the ovaries, which are located on either side of the uterus. Sites of metastasis of CA ovary, livers, lungs, spleen, intestine, brain, skin or lymph nodes outside of abdomen. Incidence rate 5.4 to 8 every 1 leg. Carcinoma endometrium begins in the uterus, the pear-shaped organ in a woman's pelvis. It is fourth most common cancer in women. Site of metastasis of CA endometrium, direct extension to cervix, rectum, vagina, lymphatic spread to iliac lymph nodes, hematogenous spread to lungs, incidence rate 4.3 every 1 leg. CA vagina, it's a hollow tube-like channel between the bottom of uterus outer surface of body. It is contribute 2% of gynecological malignancies. As per FIGO, International Federation of Gynecological and Obstetrics, cases should be classified as vagina only when the primary site of growth is in vagina only. Sites of metastasis of CA vagina, 50% of vaginal cancer arise in upper third of the vagina, most commonly direct extension in cervix, endometrium, rectum, and bladders. Hematogenous metastasis is the lungs. Incidence is 1 to 2 every 1 lakh. Carcinoma vulva. Vulva include the mons pubis, labia majora, minora, clitoris, vestibular bulb, vestibular glands, and vestibules of the vagina. It is most common seen in 65 to 70 years of age. It is contribute 4% of gynecological cancers, occurs on outer surface area of female genitalia, most commonly seen in labia majora. Sites of metastasis of CA vulva rarely seen locally spread vagina and urethra. Incidence rate 2.6 every 1 lakh. Case history, a 35-year-old female comes to the OPD with complaint of pain in the groin region for 2 months, constipation for 2 weeks, foul smelling discharge for 1 week. Patients look distressed and concerns about sexual life. The patient is known case of CA cervix. On chemotherapy, patients had inadequate pain relief with tramadol 50 mg 1 tablet BD. Concern in gynecological malignancy affect relationship, physical, psychosexual, spiritual, and social relationship of patients and their families. Palliative care in gynecological malignancies. Palliative surgical and non-surgical interventions are generally required in the setting of incurable, advanced, or recurrent gynecological malignancies. Patients' cure of disease may require intervention when problem develops as a result of side effect of curative treatment. Physical concerns, it include pelvic pain, vaginal bleeding, fistula, vaginal dryness, vaginal discharge, urinary incontinence, lymphedema, deep vein thrombosis, symptomatic anemia, malignant bowel obstructions, constipations, diarrhea, nausea and vomiting, pleural effusion, and ascites. Pain in gynecological malignancies. Pain is the most common and most distressing symptoms found in gynecological malignancy. Gynecological cancer pain is multifactorial in etiology, multidimensional in nature, may be mixed type. Gynecological cancer pain broadly classified into following types: somatic pain, visceral pain, neuropathic pain, bone pain. Somatic pain associated with soft tissue infiltration, treatment related muscles spasm. Visceral pain associated with ascites, malignant bowel obstruction, increased tumor burden, and metastasis. Neuropathic pain associated with damage, compression, infiltration of nerve. Bone pain associated with direct tumor invasion of bone structure, bone metastasis, most commonly affected bone, lumbar vertebra, and pelvic bone. How to manage pain? Treatment depends on the type and pathophysiology of mechanism. Pain should be managed with analgesic as per 3-step WHO analgesic leader. WHO in 1986 proposed 3-step leader patterns for cancer pain treatment. Step 1 for mild pain, step 2 for moderate pain, step 3 for severe pain. Most common neuropathic pain in gynecological cancer due to malignant lumbosacral plexopathy caused by neoplastic infiltration or compression. Most frequently associated with cervical tumor involve the plexus by direct extension from intrapelvic neoplasm. Most patients develop numbness, paresthesia, or weakness of lower limb. Sign includes leg weakness due to involvement of multiple nerves, sensory loss, cross dermatomes, reflex asymmetry, focal tenderness, leg edema, positive SLR test. Neuropathic pain, it can be managed by according to IASP. First line therapy includes gabapentinoids, SNRI, TCA. Second line therapy, lidocaine, tramadol. Third line therapy, botulinum toxins, strong opioids. Bone pain. Bone pain is usually associated with direct tumor invasion of bone structures. Bone pain may be focal, multifocal, or generalized. Most common cause of bone pain are bone metastasis. Bone metastasis most commonly found in cervical, ovarian, endometrial cancer, or rarely found in vaginal and vulvar cancer. It can be managed by NSAID, corticosteroid, bisphosphonate, zoledronic acid, 4 mg IV given over 15 minutes once per month. If renal function inappropriate, then use pamidronate 60 to 90 mg intravenously into 50 ml of crystalloids over 4 to 8 hours. If intractable pain can be managed by interventional procedure, it includes hypogastric plexus neurolysis and ganglio-impart neurolysis. Hypogastric plexus neurolysis indicated in cervix, uterus, proximal vagina, ovaries, rectum, and distal colons. Ganglio-impart neurolysis indicated in perineum, distal vagina, distal rectum, anus, vulva, and distal urethra. Vaginal bleeding is one of the main symptoms that needs to manage as soon as possible. Abnormal vaginal bleeding is the most common presenting symptoms of cervical, endometrial, and vaginal cancer. According to etiology, anatomical and generalized. Anatomical includes local tumor invasion into blood vessels, tumor surface bleeding, skin bone sentinel bleeding through complicated genital fistula. Generalized includes platelet disorder, bone marrow involvement, DIC, liver failure, medications, concomitant disease. It can be managed by tight vaginal packing. Packing with simple roller gauze should be carried out to control bleeding. The pack is in situ. Patients should be on continuous catheterization as she may have difficulty in passing urine due to compression on the urethra. Simple measure like restricting patient's mobility, foot and elevation, hemostatic agents could enhance effectiveness of the vaginal packing. Low-grade bleeding can be controlled by IV tranexamic acid in a dose of 10 mg per kilogram 3 to 4 times per day. Measure to control bleeding, adequate blood volume should be replaced with packed red blood cells or plasma. Hemostatic radiation or radiotherapy can be given in enhanced dose of 30 gray in 10 fraction. Uterine artery embolization or surgical interventions like uterine or hypogastric arterial ligation if when vaginal packing failed to control bleeding and hemostatic radiotherapy is not possible or indicated. Use dark towels and basins at bedside. If excessive bleeding in end-of-life situation occurs, only sedations to the patients to relieve discomfort and care of the relatives is important. Fistula is a pathologic and abnormal communications between two internal organs known as internal fistula or between skin and internal organs known as external fistula. Fistula may be single or multiple. Cause of fistula includes cancer-related and treatment-related. Cancer-related due to local progression of disease and loco-regional relapse of disease. Treatment-related due to surgery include hysterectomy, radiotherapy, chemotherapy, invasive diagnostic procedure. Fistula may cause urinary incontinence, pain, itching at fistula site, infection, electrolyte imbalance. dehydration, malnutrition, bleeding, psychological problems. It various fistula in gynecological malignancy. It includes vesico-vaginal, maybe due to outcome of hysterectomies, abnormal opening that develop between bladder and vaginal wall. Two orifices are one semi above the trigon of bladder and anterior wall of the vagina. Rectovaginal and enterovaginal, consequence of radiotherapy on the pelvis with necrosis of vaginal rectal wall or hysterectomies. It can be managed by depend upon life expectancy of patients. If life expectancy is less, various conservative management will help. If life expectancy is more with good performance score may be managed by surgical approach. Conservative management, it includes skin care, local disinfections, control of odors, control of infection with the use of antibiotics, control of local itching and pain, anti-secretory treatment, octreotide use. According to patient surgically fit and surgically not fit, vesico-vaginal fistula, if patient surgical fit, it can be managed by abdominal vaginal approach and reconstructive surgery. If patient non-surgically fit, then includes bilateral nephrostomy, urinary catheters, suprapubic catheters, partial relief, continuous use of incontinence aids, pads, panties, diaper. Rectovaginal fistula, surgical fit patients managed by colostomy, surgical non-fit patients managed by incontinence aids, enterovaginal fistula, surgically fit patients managed by enterostomy, and surgical not fit patients managed by incontinence aids. Vaginal dryness, a permanent side effect of radiotherapy is vaginal dryness, vascular and tissue damage, thinning of the epithelium and atrophy of the vagina with a reduction in elasticity and development of fibrosis. About a third of women suffer from vaginal stenosis, obstructions by scar tissue after pelvic radiotherapy. Vaginal dryness can lead to pain and discomfort during intercourse and may cause psychological problems also. It can be managed by vaginal moisturizer is contain purified water, glycerin, mineral oils, hydrogenital palm oils, lubricants, prevent genital irritation, abrasion, vaginal tears, water or silicone-based lubricants, topical estrogens, post-radiotherapy use of Falacept vaginal dilator 3 times per weekly, each time for 5 minutes may help in avoidance of adhesion formation in the vagina. Vaginal discharge. Vaginal discharge is a common symptom of certain type of ovarian cancer like germ cell and stromal cancers. Normal discharge is usually milky white or thin and clear and typically have no odor. When it is yellow, green, frothy and foul smelling, thick and white like cottage cheese, it is abnormal. Sign of abnormal vaginal discharge, vaginal burning during urination, change in color, consistency of amount, itching, discomfort or rashes, foul odor, yellowish green, grayish white discharge. It can be managed by regular bath in warm water with antiseptic solution. Systemic antibiotics and metronidazole could help in reducing the odor and infection. Cases of ovarian cancers where radiotherapy has not been received, tumor regressions may be tried with local radiotherapy in palliative measure to reduce size. Local excoriation of bulbar skin could be prevented by application of local emollients like Vaseline or petroleum jelly. Inflammatory purulent discharge due to bulbar, vaginal, urinary infections and tumor growth. It can be managed by disinfectant solution betadine chlorhexidine. Mycotic discharge due to dysmicrobia of genitalia and immobile patient. It can be managed by antimycotic suppositories, ointment, cream with probiotics and frequent hygiene and disinfectant. With blood content discharge due to severe inflammations, atrophic mucosa, post-radiotherapy, fistula, tumor growth. It can be managed by disinfected vaginal packing in if tumor bleeding with fecal content discharge, fistula due to fistula, fecal incontinence. It can be managed by surgical approach, best hygiene, and skin care. Urinary incontinence, it might be due to primary large cervical growth, residual recurrent progressive disease, post-radiation, and surgical fibrosis. Clinically associated with slow urinary stream, sensation of incomplete emptying, urinary hesitancy, urgency, nocturia, hematuria, pain, agitation, and distress. It can be managed by urethral catheters, clean intermittent catheterizations, indwelling urethral catheters, suprapubic tube, percutaneous nephrostomies, retrograde ureteric stenting, urinary incontinence resulting from fistula to the vagina and rectum is usually best managed by urinary diversion. Lymphedema. Lymphedema is the abnormal accumulation of lymph fluid under the skin and subcutaneous fatty tissue, leading to swelling of limb, permanent skin change, and cellulitis. Lower leg edema is common in gynecological malignancies. Disabling edema is the lower extremity, may be due to large tumor obstructing vein, lymphatic deep vein thrombosis as a part of generalized edema with hypoproteinemia. Signs and symptoms include pain, swelling, reduced range of motion, genital lymphedema, and difficulties such as activities of daily living as sitting or walking. It can be managed by with combination of physical techniques, compression, massage, exercise, skin care, limb elevation. The combination of this technique is effective in reducing the volume of lymphedema and incidence of cellulitis in chronic lymphedema. Vulvar swelling is especially bandaged with Velcro straps and odor control pads can of use. Deep vein thrombosis, about 38% of gynecological oncology patients develop deep vein thrombosis in the post-operative periods. Pulmonary embolism causes a large number of deaths in high-risk patients for deep vein thrombosis in cervical and uterine cancer patients. First-line treatment use anticoagulants, deep vein thrombosis prophylaxis with low molecular weight heparin, and pneumatic compression is helpful in the prevention of DVT in the post-operative periods. Vena cava filters are used to prevent pulmonary emboli when due to deranged coagulation profile and anticoagulant are contraindicated. Symptomatic anemia due to vaginal hemorrhage, it is the common in gynecological malignancies. Chemotherapy, compromise, hematopoietic, decreased oral intake may also lead to anemia. It can be managed by oral and intravenous hematinics. Severe anemia due to hemorrhage needs to be managed by blood transfusion. Malignant bowel obstructions. 20 to 50% of patients with ovarian cancer develop malignant bowel obstruction. In patients with gynecological cancer, bowel obstructions can be partial, complete, single, or multiples. Mechanical obstruction of bowel is caused by occlusion of the lumen. A dynamic paralytic intestinal obstruction is a functional obstruction. Infiltration of mesentery, bowel muscles, and narrow tumors cause physiological obstruction. It's caused by primary, secondary, abdominal, or pelvic cancers, anti-cancer treatment, abdominal, pelvic radiation, enteritis, or surgical adhesion. Clinically manifestation includes nausea, vomiting, abdominal distensions, colicky pain, continuous abdominal pain, and constipation with or without flatus. It can be managed by single level obstruction and good functional status. Surgical interventions may help, including bowel resections, operative bypass, stoma formation, endoscopic stenting, and SAMS. Multi-level obstructions, poor prognosis, are rarely surgical candidate, managed by analgesics, prokinetic, and anti-secretory like octreotide and steroid therapy. combined with parenteral hydration, nasogastric tube drainage, and venting gastrostomy. Constipation pelvic recurrence can lead to partial or complete bowel obstruction, or it may be due to the side effect of narcotic analgesic. Constipations are common for ovarian and vaginal cancers caused by changing diet, inactivity, opioids use without laxative, or varying degree of tumor-induced intestinal obstruction. It can be managed by prevention and self-care are important. Lifestyle modification, correct toilet position, proper use of fried laxative, stool softener, docusert liquid paraffin, stimulate laxative, bisacodyl sodium, picosulfate, osmotic laxative lactulose, suppositories, and enema. Diarrhea, radiation enteritis, and proctitis are the most important cause of diarrhea in case of gynecological malignancies. It can be managed by anticholinergic and opiate derivatives such as loperamide, codeine, diphenoxylate sodium with atropine and cholestyramine. Maintain fluid balance and steroid enema help in symptomatic relief. Nausea and vomiting, uremia or bowel obstruction or metabolic imbalance may be responsible for nausea and vomiting. Hypercalcemia induced by gynecological malignancy may produce nausea and vomiting. It can be managed by the correctables, food, drink, dietary modification. Acupuncture, psychological technique includes yoga, progressive muscle relaxation training. For immediate symptomatic relief of nausea, phenothiazine, antihistamine, steroid, or 5-HT antagonists can be useful. Pleural effusion, malignant pleural effusion is a frequent complication of patients with advanced ovarian cancer, less frequently in endometrial or cervical cancers. The main aim in this patient is to relieve respiratory distress by removing the pleural fluid. Fluorosis, bleomycin, or tetracycline can be tried. Continuous indwelling small catheters drainage is a relatively new technique. Ascites in gynecological malignancy. Malignant ascites is most frequently associated with ovarian carcinoma. Most common cause of ascites increasing intraperitoneal vascular permeability. It is associated with increased intra-abdominal pressure, discomfort of patient abdomen, discomfort of abdomen, bloating, nausea and vomiting, esophageal reflux, poor mobility, insomnia related to general discomfort, pain in groin and subcostal region, and lower limb. It can be managed by diuretic therapy, include spironolactone 50 milligrams daily, furosemide 20 milligrams daily, abdominal paracentesis, octreotide, somatostatin analog to reduce the volume of ascites, peritoneovenous shunting, a tank of catheters. Psychological issue in gynecological malignancies. Psychosexual issue after treatment of gynecological cancer needs to be addressed. Poor body image, depression, decreased interest in sex due to dryness and shortening of vagina, commonly found in the post-treatment phase of gynecological cancers. It can be managed by multidisciplinary approach, including psychological treatment, symptoms management, proper psychological counseling should be provided for the effective treatment of psychosexual difficulties experienced by patients. Quality of life issue. The issue of dignity and quality of life in women with progressive incurable cancer and survivor of cancer needs to attention in our country. These women may get neglected in developing countries like India due to resources constraint, overburdened health system, and lack of training of staff to deal with such kind of issue. At different phases of disease, readjustment of goals may be required. The patients and family members should never be left abandoned in the end at the time when all possible cancers control targeted therapies are exhausted. This is a phase of extreme crisis and distress and needs sympathetic support and counseling to make proper decisions. Coming back to our patients on general examination, patient is conscious and oriented. General condition is fair, vitals stable, NRS 8/10. Management for pain opioids were given. For pain opioids were given morphine titrated and started with a dose of 10 milligram, 1 tablet 4 hourly, plus 1 tablet SOS along with adjuvant analgesics. For constipation, bisacodyl 5 milligram, 2 tablet BD was given. For purulent vaginal discharge, antibiotics given. For psychological distress, counseling was given and was referred to psychiatry department for further management. Take-home message: symptomatic management play a major role in the management of end-stage gynecological cancers. Gynecological cancer is a disease that can have psychosocial and psychosexual impact on patient. Multidisciplinary approach has better holistic management of the symptoms. Partner of cancer patients do not always have the skills to provide adequate support to their female partners. Caregiver education is important part of the management. Thank you.
Dr. Yogendra, you want to summarize and take up the questions?
Thank you, Surendra. The problems of the gynecological symptoms in palliative care that we discussed represent delicate and intimate sphere, and it may disturb patient autonomy and dignity. So it is related to the patient autonomy and the dignity. The mission of palliative physician is to consider treatment options thoroughly in context of patient quality of life, prognosis, and life conditions to fulfill the ideals of the best symptomatic and supportive care. A woman cured of disease may suffer debilitating side effects like radiation proctitis and various fistulas. They need appropriate surgical management to improve their quality of the life. Agony of a woman who suffers with continuous leaking of urine and the feces from vesicovaginal fistula and rectovaginal fistula can be understood by none except her. So this is the symptoms that need to be focused in gynecological oncology in palliative care. So providing holistic care to patients suffering from various physical, psychosexual, social, and spiritual suffering can make a phenomenal change in their quality of the life.
Anyone has any questions? Dr. Ravi Karan is asking Yogendra.
Yes, ma'am.
Can you please elaborate on radiation proctitis management if not having a specialized retention enema in the ward?
Yeah, radiation proctitis is due to the radiation on the pelvic or on the pelvic part. It present with the diarrhea. Radiation proctitis present with the diarrhea. It can be prevented by the using anti-inflammatory enema like steroid enema. Yeah, and so many part I don't know, madam. If you can focus here on this radiation proctitis.
Madam, you are on mute.
Dr. Jennifer, can you answer this question, please?
Thank you. Thank you for the good presentation. Yeah, so radiation proctitis is actually a long-term complication of radiotherapy to the pelvis. And it can present with a lot of hematochezia, increased frequency of stools. So the first thing usually to differentiate whether it's a recurrent CA's carcinoma cervix infiltrating the rectum or it is a treatment-related complication that is important. So most of them will need a proctosigmoidoscopy or a colonoscopy to rule out the cause of hematochezia, and usually they will see findings of telangiectasias and active bleeding, and usually a biopsy is also taken. So the treatment is generally conservative to keep the stools as soft and as loose as possible, to ask them for low fiber diet, to give enemas, steroid enemas. In some situations, if the facility is available, argon plasma coagulation. So we had this done for a couple of patients with very good symptom relief from hematochezia and bleeding. So you will need a good gastroenterology support system if for this procedure. In very rare conditions, if it is really bothering and not at all settling, patients have ended up needed colostomy. So this is about radiation proctitis. I just wanted to add on a couple of things about patients with disease progression and going on to rectal obstruction. So basically, sometimes they present with fistulas. That is when this infiltration happens and finally end up with fistulas, where surgical option of colostomy is needed, especially if their prognosis is good and otherwise ECOG is good, and rectal incontinence is a major problem. But one thing to look forward to, not look forward, but keep looking, is if they are presenting with symptoms of rectal obstruction. So they can have symptoms of painful defecation, frequent defecation, incomplete defecation. So it is important to do a vaginal perrectal examination to look at the rectal lumen. And if you think the rectal lumen is getting compromised, you should not wait for complete rectal obstruction or for them to develop a fistula, but empirically colostomy can be talked and planned. One other common complication with the carcinoma cervix is obstructive uropathy. Sometimes they present with obstructive uropathy, but sometimes with recurrent CA cervix, you see them presenting with obstructive uropathy, high creatinine, either normal output or low output urine. And again, this is a situation where a lot of discussion and informed decision making has to be done, depending on whether the age, the prognosis, whether it is presentation, whether they've had treatment before or not had treatment before, because many of them might end up with bilateral percutaneous nephrostomy. So again, this is a situation we need to keep in mind, whether we need to intervene, how do we make an informed decision with patients. I think you also mentioned foul smell, but that again is a big problem, and adding metronidazole in graded doses based on the level of foul smell is also important, because these all really impact their own quality of life and also the social this thing. Thank you.
Dr. Jennifer, Dr. Preeti is asking how much is the safe dose of steroid enema, and then Dr. Punitha is asking which steroid is preferred for enema, in which condition can we give?
So these steroid, the steroid enema comes as steroid enema sachets. So sorry, immediately I can't tell I am not aware of the dose, but they come as sachets as enema. So you will, the dose I can find out and let you know, but enteroform enemas are available, so that can be given. What was the other question?
Which steroid is preferred for enema?
So these, this comes as I will just look up and put it on the thing. Enteroform enema. So the dose and the name I not aware immediately. I will put it up on the chat.
One more question, if Dr. Yogendra or Dr. Jennifer only will answer that. Does sucralfate enema helps with?
Yes. The sucralfate enema also can be tried.
Good morning, ma'am. May I add something? This is Meenakshi.
Dr. Meenakshi, please go ahead.
Ma'am, I think the enteroform enema is prednisolone, and in a low resource setting where it is expensive to buy enteroform enemas. If it's not possible, I think IPM in Calicut we have used hydrocortisone, the regular one, the intravenous one. You mix it and make it up to a volume of about 100 ml, and that has also been used as a retention enema from another lecture, I remember. And I just wanted to add one point about malignant ascites in ovarian cancers. Dr. Surendra mentioned that the role of diuretics, but mostly in ovarian cancers, it is an exudative ascites. So the role of diuretics there is a bit dicey. So one has to find out whether it's a transudate or exudate. Mostly it's exudated. So sometimes diuretics may not be helping, and we might need to be tapping quite often, or go for other pigtail insertion or Pleurex catheter insertion. Thank you, ma'am.
Thank you, Dr. Meenakshi. Thank you very much.
So enteroform enema has hydrocortisone. Like Dr. Meenakshi said, it is some 800 rupees per use. So it is costly. It has got hydrocortisone.
Thank you. Thank you, Dr. Jennifer and Dr. Meenakshi. Anyone asked more? Let me see. Any questions? I don't think there are any. So thank you very much, Yogendra and Jitendra, both. Satinder. Okay. Thank you very much for nice presentation. You have covered a lot. And Dr. Jennifer and Dr. Meenakshi has added a lot of good comments. Anyone want to say anything? You can open your mic and say. Otherwise, we will like to start.
Good morning. This is Dr. Anshu. Good morning, Sushma Didi.
Yes, Anshu. Yes, please go ahead.
Good morning. Am I audible?
Yes,
I just wanted to know that during palliative care and gynecological, these malignancy, highly advanced malignancy patients, do you counsel the patient's spouse also? Are there sittings with the patient and the spouse also regarding
Yes. It is
psychological build-up, Okay. So how do they go about it? I just wanted to know a couple of sentences. How do you talk to the spouse of the patient?
So probably first we would like to discuss this. Like, this is important that first we should talk to the patient, and if simultaneously spouse should be always there if possible. We'd like to ask them that what exactly they have understood about the disease.
Okay.
And what are the consequences of having bleeding and all these problems of rectovaginal fistula, consequences of the therapy. And then definitely this is very important to ask, to tell them that about what should be how their sexual life should be. It is important that should definitely discuss this. I still remember one of my patient, she was from a remote Bihar, and she was staying here for 2 years with her brother and was getting treatment over here. And when she started, I realized that she has got limited life and she should go back to home. And when I asked her that, please go back to your village, because her children and husband was there in the village, and brother was she was getting treatment with her brother. She came, she was very sad when she came, and when I asked her that you go back to home, and this Diwali, definitely this was Diwali time, and you will go back and you should celebrate Diwali, because I knew that this will be her last Diwali. And when she came again after 5 minutes, and she asked me that whether can I have sex with my husband. So when I said yes, you can do. So because she was not a case of CA cervix, she was case of CA pancreas and gallbladder, getting treatment, and now she was in the end stage. She was so happy, and she was so happy and cheerful, and immediately She started calling her husband that I'm coming, and it was a huge difference. So it is an important thing which we should explain to the patient whether they can have and whether they cannot, or if they will have, what are the various problems they should anticipate, and what are the precautions they should take. I think this is important, Anshu, and it is best to ask them that whether they have understood the gravity of situation. And once they have understood, if they have not understood, then we should make them understand that what exactly is happening and what are the consequences of various therapy and disease progression.
That's very important answer you have given, Dr. Sushma Didi, because this was one question which was lingering during the seminar. Thank you so much, everyone. Thank you.
Anyone? So I can see so many people from all over country, and I have met almost everyone in the Bangalore. I think we are so happy that everyone is joining Monday seminars. Next week, we will again see you before 6:30. Thank you, Dr. Jennifer, for your always your giving your valuable comments. And thank you, Dr. Meenakshi. I can't see anyone else is asking any question. And Dr. Satyendra and Dr. Yogendra, just see the comments. Everybody is appreciating your lecture. So thank you, Nisha and Archana, for keeping everybody on track. Thank you very much. We'll
Thank
see
you,
you next
everyone.
week
Thank you.
before 6:30.